Yes. So moving into the next scenario, 65-year-old male, FBS of 220, ppbs of 260, HbA1c of 9.0. On metformin, 1 gram per day. The creatinine is 1.8. What option of insulin would you consider? Because the patient might be having CKD, probably diabetic kidney disease. Okay, so in this case, the insulin options would be again NPH or a long-acting insulin like Glargine or Degludec. Since there is a slight rise in the ppbs, you can even consider pre-mixed longer-acting insulins like Rhizodec, like that's got fast-acting insulin aspart along with insulin Degludec. That's also pre-mixed. Pre-mixed insulins are fine, like 30, 70, 50, 50. All these options are good, depending on the patient's choice and affordability. Suppose you had to start a oral anti-diabetic drug for this patient. The patient is not willing to start insulin. What would be the choices? Gliptin, which gliptin? Glycoside, spot on. Yes, good option. Glycoside is a renal safe sulfonylurea. Linagliptin, exactly. Linagliptin is approved for usage in all stages of CKD. So that's a good choice, right? So you can consider linagliptin. You can consider, as someone said, glycoside. One more drug. Suppose the patient's weight is normal. His BMI is around 22, 23, 24, like that. Not too much overweight. Even if he's overweight, can be still tried. One more choice of an oral anti-diabetic drug, which we don't really think of. And we've already discussed that drug. Very underused. DAPA, again, a good choice. Yes, DAPA can be considered. It will also probably retard the progression of CKD in this patient. Good choice again. Yes. Pioglitazone can be tried in this patient. Okay. It is still renal safe with very no risk of hypoglycemia. Just watch out for the adverse effects, which can happen in a small number of patients, but a good choice. So we have got options here. So it's a myth in our minds that patients who are having kidney disease should be on insulin. Actually, we discussed longer acting options like Lantus and all those things here. With CKD, you have to be careful because in these patients, if they have hypoglycemia, the insulin's metabolism or the time in the body may be delayed significantly in some people. So if they tend to have hypoglycemia, the hypoglycemia can keep on recurring for much longer time than you would expect in a normal patient. So be very careful about the duration of insulin which you're using. In patients with CKD, it's better to stick to regular insulins, shorter acting insulins or NPH insulin. You can give Lantus, there's nothing contraindication about that, but it should be taken with safety. Make sure the patient does not have risk of hypoglycemia. Someone has mentioned that tenligliptin can be given in CKD. Yes, it can be given to mild to moderate stage of CKD. In severe CKD, the data is not very much reassuring. That's the only problem. The studies are limited. It's not as well studied. It may be studied, but it's not as well reported or as extensively reported as, say, sitagliptin, vildagliptin, or linagliptin. That is the only issue with that. And the thing is, another interesting thing is with the market now being flooded with off-patent sitagliptin and vildagliptin, we have got much more studied choices of drugs among the gliptin class to choose from at a cheaper rate. Tenligliptin was the choice of gliptin for most of our doctors because it was affordable and accessible. The sitagliptin and vildagliptin very expensive, but since they have gone off patent in the last few months, they are very proud entrants into our armory. What if creatinine is over 4? Okay, perhaps in that case, linagliptin can still be considered at a low dose, 2.5 mg. Although no dose adjustment is recommended for linagliptin, it's mainly hepatic metabolism. but you can start 2.5 or 5 mg of linagliptin, no problem with that. In that particular patient, perhaps it's better to start put that patient on 2 times daily NPH or at least nighttime NPH. Try to get the fasting under control. See whether the ppbs is coming down proportionately. If the ppb is not coming down adequately, then you can start on pre-mixed insulin 2 times a day, 30-70 or 50-50. You can start 2 times a day and see how it behaves. So the more the number of complications in the background for the patient, the more watchful you have to be with what are options you are starting for that patient. So all these scenarios can be correct. Okay. Elaborate about the utility of saroglitazar. I think, yeah, we'll come on to that later on. It's a very good question. And the answer goes very close to pioglitazone. We'll come back. Just remind me to come back to it later. Right. So if the BMI is of 23, you can consider linagliptin. BMI of 30, you can consider gliptin, pioglitazone. It's all okay. Pioglitazone and sulfonylurea like gliclazide can cause minor weight gain in this patient. Dapagliflozin would be one of the drug of choices for this patient, considering if the BMI was 30. Yeah, so all the options have been discussed for this patient. Scenario number 11. 60-year-old female with a FPS PPBS of 240 and 250, HbA1c of 8.3 on metformin, glimepiride, sitagliptin. The patient has got coronary artery disease, creatinine of 1.4. Willing to start insulins. The patient is willing to start insulin. But what options do you have with or without insulin? 240 and 240 and 250. In this case, probably dapagliflozin would be, or the gliflozin class of drugs would be of choice. It may retard the progression of CKD. It has got a protective role in coronary artery disease, cardioprotective role also. Both the fasting and ppbs are about 200, and it can reduce the HbA1c by 1 to 1.5 points. Since the patient is willing to start insulin, again here any insulin would be in contention, any of the medium acting or long acting insulins like NPH at night to start with, or Glargine or Degludec. Anything is okay. Once daily insulin at night preferably to start with. Try getting the fasting in control. If the ppbs remains high, maybe a premixed insulin could be considered twice a day. The last scenario, a 68-year-old female, FBS of 140, ppbs of 240, HbA1c is 7.8, creatinine is 1.6, BMI is 27. What are the options? This question is more or less a revision of all the previous slides. First time detected diabetes. Unfortunately, at the time of detecting diabetes also, her creat is 1.6. I'm not going into the EGFR and CKD, EPI and all those things. I think they're beyond the purview of this topic, so I'm not going into that. Let's stick to creat for the sake of this discussion. What would be your choices? Can you start metformin? Metformin can be considered as a as one of the starting drugs in mild to moderate CKD. It's okay to start 500 mg per day, which would most probably suffice for this lady. A gliptin and insulin. A gliptin would be okay. Linagliptin is a good drug of choice for this person. Insulin is also good. We have discussed about insulins in the previous slides. Since the experience is not far off, maybe she can do with a small dose of premixed insulin twice a day. Yes, her body mass index is 27. Her FBS is okay. Mainly it's the ppbs which is of a problem, bit of a problem. Voglibos may be considered. It may give a small reduction in the postprandial blood sugars. Any other option? Dapagliflozin is one of the drugs which can be considered, but it's not usually a first-line choice. So I think metformin, small dose, linagliptin in usual dose, BMI is 27, no harm in trying pioglitazone at a low dose, and the insulins, which are medium acting or long acting, maybe once or twice a day, should suffice for this lady. So the last slides, the take-home messages would be, we might know about guidelines and drugs and the mechanism of actions and everything, true, but we have to use that knowledge to individualize patient care. For the same fasting sugar, PPBS and HbA1c, executive might be treated differently from the pharmacotherapeutic point of view compared to an auto driver, compared to a, say, industrial worker engaged in hazardous activities, compared to a elderly lady who's about 75-year-old who can't handle insulins and tablets as well. Remember, guidelines are guidelines. Even though some guidelines may say that only 3 drugs should be tried and after that the 4th should be insulin, it might not be always practical in our scenario. Patients might not like it. It might not be practical because patients can't take it. So in that case, it might be okay sometimes to consider a 4th or a 5th oral drug also. Help the patient, not just treat the report. So if we see a FBS of 140 and a PPBS of 150, that might be looked upon differently or interpreted differently from of FBS of 140 and a PPBS of 250. So it's not the report of 250 that should be treated. Look at the patient's lifestyle and then again look at the patient's affordability, compliance likelihood, and then treat the and help manage the patient. Know the common contraindications and adverse effects of drugs. That's a given. So there's a question whether which OAD is safe in pancreatitis. It's said that gliptins can cause pancreatitis. There are reports like that, but in practice, actually the incidence is very, very low. In our area, when we attend the diabetic meetings, we have a forum for diabetes in our district and our region. We have not heard of pancreatitis being caused confirmed by a gliptin. In fact, I have a patient who has had alcoholic pancreatitis and has been on a gliptin after recovery over the last couple of years without any adverse events. He doesn't want to he doesn't want to avoid the gliptin because he's more worried about hypoglycemia. He's on metformin and a gliptin and is doing very safely, very well so far. He opted to continue the gliptin despite the risk of pancreatitis. So most of the OADs are indeed safe in pancreatitis, but you have to be careful. Sometimes people with pancreatitis might behave like type 1 diabetes. That means the OADs might not work. In those patients, insulin should be the drug of choice. Saroglitazar and Rhizodec. Okay, saroglitazar is interesting actually. It was launched in the name of Lipaglyn. It is actually an Indian molecule, if I'm not mistaken. Studies are mostly Indian based. And as we know, whatever is Indian needs a long time to be accepted by the rest of the world. The best example would perhaps be ORS. ORS, though not strictly Indian, it was developed in the India-Bangladesh border in the 1970s. And it brought down the death rates of cholera by about 60 to 70%. That is how much impact it created. Simple oral rehydration solution. It took the West about 25 years of studies and observation to accept that, yes, ORS is better than IV fluids. I think something like that is playing along with saroglitazar. It's a wonder drug. Perhaps again, the only drug in its class, it goes very close to pioglitazone. It does not cause hypoglycemia. It can be given in non-alcoholic fatty liver disease. It can reduce the HbA1c to the tune of 0.5 to 1%. It should not be given along with the pioglitazone. Obviously, it can be tried with metformin. The usual dose is 4 mg once daily in the morning, usually before food. Again, it costs about 25 to 30 rupees per tablet. So affordability might be an issue. If there is gallbladder disease, it's better to avoid it. These are the basic points about saroglitazar. Rhizodec is again a very interesting combination of insulins. It's got a very fast acting short-acting insulin, that is insulin fast-acting aspart. That's about 30% in it. The remaining 70% is insulin degludec. That's a ultra-long-acting insulin. So the fast-acting component will start acting about 5 to 10 minutes after injection, and the ultra-long-acting insulin will start acting about 1 or 2 hours after injection. Again, I'm not going into the details of how the drug is delivered, how it is a co-formulation and not a premix, how it goes under the skin, and the polymers get rearranged and then get released one by one when the zinc molecules get detached from the polymer. I'm not going into all that. Just mentioned it. The thing is, so since it's got 30% of ultra fast acting insulin and 70% of very slow acting insulin, it can be given before any major meal of the day. It can be given once daily or twice daily. Most of the times it's given once daily. And the best thing about injection Rhizodec and injection Degludec alone, that is Tresiba injection, is that it can be given at any time of the day. Tresiba does not have any correlation with the meal timings. It can be given anytime, before meals, after meals, whenever the patient remembers is okay, because it's got only one single type of insulin, which is ultra long acting. Rhizodec, better to club it just before the meals, because 30% of it will be working along with the postprandial glycemic surge.